Let's jump right in. Welcome to part 2 of our explainer series on vestibular rehabilitation. Today, we're zeroing in squarely on patient-reported tools. As clinicians managing dizziness, we're well aware that performance-based tests, well, they really only tell half the story. To grasp what's actually going on, we have to map out the patient's internal experience, their perceived handicap, and honestly, their everyday balance confidence.
This explainer is based on the literature review Outcome Measures in Vestibular Rehabilitation, Selecting, Interpreting, and Acting on Patient and Performance Tools, published by Australian Dizziness Clinics, available at australiandizzinessclinics.com. So let's kick things off with a bit of a paradigm-shifting question. Why are subscale patterns way more useful than total scores? Look, we've all been there, right? A patient hands back their questionnaire, we tally up that final score, and we kind of just let that single number dictate how severe their condition is. But treating the total, that's a massive clinical pitfall. A total score is just an aggregate. It totally obscures the nuance. It's the subscales within these tools that actually reveal the true clinical picture and tell us exactly where to refer them or what treatment pathway to take.
It really comes down to this core imperative. The number you act on is the pattern, not the sum. We literally have to shift our focus from just doing math and adding up numbers to actually identifying actionable symptom dominance. Think about it. If you only look at the sum, you could completely miss a severe emotional dominance that needs a totally different approach than someone with a purely physical provocation.
Here's our game plan for today. 1. The power of subscale patterns. 2. Court questionnaires. 3. Specific screens. 4. Driving action through patterns. And 5. Measuring patient change. Let's get to it.
Section 1. The power of subscale patterns, and why we have to look way beyond the total score. Let's break down the difference by picturing two contrasting presentations. On one hand, imagine a patient with a super high emotional score on the dizziness handicap inventory combined with a really low score on the activity-specific balance confidence scale. This specific pattern is practically screaming for a psychology referral. Their handicap is totally driven by anxiety and a fear of falling. On the other hand, imagine a patient with a high physical subscale dominance on the DHI. That points straight to active movement-based provocation. Two patients that literally have the exact same total score, but those subscale dominances, they dictate completely divergent immediate treatment pathways. Moving into Section 2, our core questionnaires, specifically the basics of the DHI and the ABC. First up is the Dizziness Handicap Inventory, or the DHI. It's 25 items scored from 0 to 100, but crucially, it's chopped up into emotional, physical, and functional subscales. A baseline score over 40, that tells us there's significant handicap. Anything over 60 is severe. But again, and I can't stress this enough, you absolutely must drill down into those subscales. That's how you find out where the patient's functional impact is actually concentrated, which is what guides your whole clinical emphasis. Now, I want you to anchor this number in your mind. 18. An 18-point drop on the DHI is your minimal clinically important difference, or MCID. This is the absolute smallest change that actually means something to the patient. It's such a common pitfall to report a statistically significant change, like a tiny 2-point drop, without this MCID context. That just misleads everyone, patients and referrers included. You need to see that 18-point swing to know for sure you're making a real tangible impact. Next, we've got the Activities-Specific Balance Confidence Scale, or the ABC. This one asks patients to rate their confidence across 16 everyday tasks, which gives us a mean percentage score. Now, a massive red flag here is any score under 67%. That is a validated marker for increased falls risk, and you have to address it. It's a phenomenal tool for tracking anticipatory anxiety and figuring out if a patient is really engaging in their life or if they're just leaning hard into avoidance behaviors. And just like the DHI, the ABC has its own magic number, 10 points. A 10-point, or 10%, gain on the ABC scale is your meaningful threshold to track. It proves that the patient isn't just physically improving, but they're actively getting their confidence back and keeping it as they move through your program. Think about the typical baseline severity stacked up against the required clinically important differences. We're talking 18 for the DHI, 10 for the ABC, and 9 for the VVAS, which we're actually going to cover next. The big takeaway here? Ground every single progress note and discharge summary in these meaningful metrics. Don't just celebrate raw score swings, celebrate actual meaningful change. All right, Section 3, Specific Screens, focusing on the VVAS and NPQ tools. The Visual Vertigo Analog Scale, or VVAS, is a 14-item questionnaire that specifically rates visual motion-driven anxiety. Think about the panic of walking down a super busy grocery store aisle or watching fast-paced action on TV. The total score is the mean of those items. Capturing this specific anxiety directly informs your game plan. A high score tells you definitively that you need to push targeted optokinetic exposure and visual desensitization work. No guessing required.
So, our crucial number here is 9. That's the minimal clinically important difference you're hunting for on the VAS. If your patient starts off with high visual sensitivity, you are looking for exactly a 9-point reduction. That's what confirms your optokinetic interventions are actually translating into real-world relief for them.
Alongside visual screening, we also rely on the neck pain questionnaire, the NPQ. This is just a really quick, essential tool to screen for any cervical contribution to the patient's symptoms. It is absolutely invaluable when you're trying to rule in or out cervicogenic dizziness, or when you're dealing with those tricky post-concussion presentations where neck dysfunction almost always overlaps with the vestibular issues.
Moving on to Section 4, driving action through patterns, and how we actually use this data for treatment.
There's a clear, sequential logic to the decision pathway here. You don't just blindly throw a stack of questionnaires at a patient and hope for the best. You transition from the broad impact of the DHI to the very specific confidence metrics of the ABC. Then, using those results and the patient's history, you screen with the VAS and the NPQ. By filtering their experience through these specific domains, you land on a highly focused, tailor-made treatment intervention. It's like putting together a giant puzzle. Let's look at some concrete examples of how isolating a lagging outcome measure totally dictates your strategy. Say a patient has a high residual VVAS score, but a perfectly normal DHI. Well, they do not need general vestibular rehab. They have an isolated visual motion sensitivity, so you need to push optokinetic exposure. On the flip side, what if a patient has a really low ABC confidence score, but their physical functional gait assessment is completely fine? You don't need to push their physical limits. You need to engineer a falls prevention plan and use graded community exposure to rebuild their psychological confidence. Makes sense, right? And finally, Section 5, measuring patient change and getting the timing of your assessments exactly right. The literature is super strict on the timeline for this test battery. You absolutely must establish your objective baseline at Session 1. After that, retesting should happen every 4 to 6 weeks during the active program and then once more at discharge. But here's a warning, retesting these questionnaires more often than every 4 weeks is just wasteful. It frustrates patients because they don't see day-to-day changes, and frankly, it frustrates us too. But if you wait longer than 6 weeks, you will absolutely miss key progression triggers and stall their recovery. It's all about finding that sweet spot. I want to drop this clinical pearl straight from the source. Plot change visually for the patient at every retest. Never, ever underestimate a patient's love for a good upward trending chart. Showing a patient a graph of their DHI dropping and their ABC rising visually drives their engagement way more reliably than just reading off a single number to them. This visual curve is an absolute game changer for keeping them motivated, especially during those inevitable, kind of frustrating plateau weeks in the middle of a rehab block. As we wrap this up, I want to leave you with a bit of a provocative thought. Look at your current clinic load. Are you just tracking total scores to fill out paperwork, or are you genuinely acting on the patterns? I really challenge you to start using subscale and subdomain data to hyper-target your interventions instead of just vaguely treating the totals. It makes all the difference in the world. In Video 3, we cover performance-based tools, functional gait assessment, mini balance evaluation systems test, Romberg and dynamic visual acuity, the objective battery that pairs with the questionnaires. For additional resources, including the full literature review, the clinical cheat sheet, audio overviews, and the rest of this Explainer series, visit AustralianDizzinessClinics.com. Please subscribe to the channel and leave a rating to support the series.